This talk is actually in the best position because it combines the devices and the pathophysiology. I'm going to report about 4 different patients who offer 4 different types of pathophysiologies, but the common denominator is that these are for treatment for pulmonary hypertension and its consequences. So we have done 4 cases in Munich in the Department of Pediatric Cardiology and Congenital Heart Disease, so we also care for adults with congenital heart disease. There is an adult male with severe right heart failure in pulmonary hypertension and functional class 4. There was a child with recurrent syncope with idiopathic pulmonary hypertension in functional class 3. Then we had another younger adult with a failing frontal circulation, where a creation of a fenestration and AFR device implantation was performed in functional state 3, and an adult with a spongy myocardium on the transplant list with recurrent heart failure in functional stage 3 to 4. We will start with the last one. This was a 56-year-old male with spongy myocardial non-compaction type on the transplant list with recurrent right heart failure in functional stage 4. And the symptoms were recurrent ascites, drainage of 4 to 8 liters every 3 to 5 weeks, plus pleural effusions, and however normal liver function, and functional fractional shortening of less than 10%, ejection fraction of less than 20, with on catheterization not so impressive pressures of 15 to 20 in the left atrium, as well as PCW and normal pulmonary artery pressures, and a central venous pressure also of 50 to 20. However, because of the history and the monstrous right ventricular symptoms with huge ascites and the urge to drain this, the necessity to drain this ascites every once in a while, we decided to create a fenestration and implant an AFR device of 8 millimeters. Consequently, there was a slight improvement. The patient recovered to functional status 2 to 3, and the ascites seems to be less aggressive. However, all medications were continued as before. I would like now to show a little bit of the procedural aspects of the device. So this is the device on the table. Obviously, you can see here the 2 discs and the waist or the fenestration in the middle. And the device is very easily mobile, so offering no obstruction to any kind of position in the heart while being handled. And the development of the device is shown here, where you can see where the first disc, the left atrial, is developed, and then the second disc is shown here as it comes out of the catheter, undisturbed, especially not showing any distortion. Here we have angiographies. They are shown to demonstrate the delineation of the left atrium for the transeptal procedure, the balloon arterioseptostomy, which follows here. You can see that the puncture is done in the first slide here with the catheter turned to the rear, and then this is followed by gradual balloon dilatation. Then the catheter, the AFR device is introduced into the catheter. You can see this here before it is developed, and here it's not well seen, but I think you can sort of see it here. It is this shadow, which is the distal, the left atrial disc, and here the other side of the device is developed here. And this is the fenestration tunnel. And here there is contrast injected through the working catheter to demonstrate the shunt, which goes from right to left. The second case is a young girl 8 years old, with moderate pulmonary hypertension on catheterization, but recurrent syncope in functional state 2. She had reduced exercise tolerance and was silently depressed, very needle phobic, had triple therapy for pulmonary hypertension, which included Bosutan, sildenafil, and inhaled iloprost. We created a fenestration by gradual balloon dilation, and this was followed by implantation of an AFR device of 8 millimeters, causing a left to right shunt. I want to repeat that this child was not having severe pulmonary hypertension but recurrent syncope, so right heart failure was not part of the picture, therefore a left to right shunt followed. The procedure as such was not spectacular, it was very straightforward. However, the child changed dramatically with no further syncope, and the parents were full of praise and enthusiasm for the clinical improvement. The child turned to a happy and very alive child in functional class 1. So this is just to demonstrate the procedure in her with a left-to-right shunt. I want to lose a word about the physiology of pulmonary hypertensive crisis, which is, as you can see, a dramatic increase of pulmonary arterial pressure with central venous pressure as the sign of very fast and episodic right ventricular failure. And you can also see that the systemic pressure decreases close to shock situation. So we believe that these episodes of pulmonary hypertensive crisis or syncope or pre-syncope are in fact short episodes of right heart failure, and that they can be quite damaging to the right ventricle. We know this from intensive care, that each time of pulmonary hypertensive crisis in post-operative children sets back the child for 1 or 2 days, if not longer. And certainly having syncope and pulmonary hypertensive crisis in an outpatients will also damage the ventricle. So therefore, this is probably an explanation why this child with only syncope not only improved by not having syncope, but also by exercise tolerance and general improvement. The third case was an adult patient of 26 years with failing frontal circulation, severe scoliosis in functional state 3. He also had pulmonary hypertension treatment in order to improve the frontal circulation through the pulmonary vascular bed, had recurrent ascites, transpulmonary gradient of about 8 to 10 millimeters mercury, with recurrent pleural effusions as a sign of the failing frontal circulation. A fenestration was created, which I'm going to demonstrate in a second. A small AFR device was implanted of 6 millimeters as to not overflood the patient with blue blood and cause desaturation. Thereafter, the patient reduced the ascites or pleural effusion formation and recovered to functional stage 2. So I'm going to show the intervention of the frontal circulation first as sketches and then as angiograms. You can see here the frontal circulation as the connection of the venous returns to the right pulmonary artery, and then the pulmonary flow returns to the single ventricle, which pumps the blood into the aorta. A catheter was introduced then from above, locating exactly the transition between the right pulmonary artery and the rest of the superior vena cava, where this was in proximity with the left atrium. Then this was perforated. Once it was perforated and punctured, then balloon dilatations followed, and the rest of the intervention was trivial with implantation of the AFR device. So the most difficult part was to find exactly the right place for the perforation between the upper caval vein and the left atrium. You see here the right pulmonary artery, the upper and the lower caval vein. Then you see here the left atrium, and you see the pigtail positioned exactly where the future puncture